peripheral vascular disease. In this coming few minutes, we will study particularly the arterial disease, that is Buerger disease, Reynolds phenomenon or Reynolds syndrome, then gangrene, acute limb ischemic feature, and at last atherosclerosis. And regarding this disease, what are the important history, inspection points, palpation methods, and what are the abnormality during the auscultation. So first of all, we need to differentiate all the arterial disease, starting from the Buerger disease. Buerger disease is not atherosclerosis. The first point, that it is not atherosclerosis, not due to atherosclerosis. So these patients are usually not hypertensive, diabetic mellitus, or hyperlipidemic. There is no such symptoms, so it should be differentiated from atherosclerosis. And it is usually seen in the patient who is heavy smoker, and this cigarette is the main culprit which causes the Buerger disease. What does it causes? Actually, the smoke in the cigarette contains carbon monoxide and nicotinic acid, which is responsible for the vasospasm, and once the vasospasm starts, there is also the involvement of inflammation in the vessel. Means what happened, due to nicotinic acid and carbon monoxide, the vasospasm of the vessel was occurred, okay, and vasospasm, and then the inflammation in the arterial wall, usually in the intimal layer of the vessel, starts, and due to the inflammation there is vascular compromise. As a result, the blood supply to the limb is affected, and once the blood supply to the limb is diminished, the vessels then the collateral vessel starts to originate from this original vessel to meet the blood supply to the distal part, okay, and once this collateral are originated, they can be easily viewed under the angiogram, which shows like a cork screw appearance in the angiogram, okay, and if the person do not stops smoking and he continues smoking, then this collateral also eventually undergoes vasospasm due to the nicotinic acid and carbon monoxide, and at last the Buerger disease will result in ischemia of the limb and gangrene will be formed. So this was the relevant pathogenesis related to the Buerger disease, which affects usually the lower limb and usually seen in the smoker. So the male are more caused by the Buerger disease, and once there will be ischemia, it will be limb ischemic feature, which we will see later on. Now the Reynolds phenomenon. Usually Reynolds disease or the Reynolds syndrome is cold sensitivity. It is usually due to the cold sensitivity. As a result, the person who is you may also find some of the familial history of the Reynolds syndrome in a patient, okay, and once they are sensitized to the cold, there will be vaso-occlusion, as a result of which the person may undergo acute ischemia in the limb, and there will be diminished blood flow, and but this cold is the main key word, and the other is the lower limb, not the lower limb but the upper limb is more affected than the lower limb, and usually the proximal part of the fingers are the most common site for the Reynolds phenomenon or the Reynolds syndrome. Upper limb is more affected than the lower limb, okay. So these were some of the differentiating feature, and among these the female are more prone to have Reynolds syndrome than the male, okay. And then the gangrene is actually divided into wet gangrene and dry gangrene. This can be differentiated with the demarcation line which is present in dry. Demarcation line between the gangrenous part and the normal tissue is well differentiated in dry gangrene, whereas it is vague in case of wet gangrene. In dry gangrene, the limb is actually thin, mummified, and it is dry, and there is aseptic type of aseptic type of ulceration in dry. Aseptic type of ulceration is present in dry, and whereas in wet type there is edematous changes, edematous, and septic ulceration is present, septic ulceration, and the demarcation line is vague type. Okay, and in acute limb ischemia, we should remember that once the ischemia is developed in the limb, then the blood is diminished in the proximal part. As a result, the muscle undergoes edematous changes, means edematous hypertrophy of the muscle will be there and can cause compartment syndrome too. Okay, and the component or the clinical feature that should be remembered in acute limb ischemia is the 5 P's, and 5 P is the for the pulse may be either diminished or absent. Okay, diminished or absent. Then the paraesthesia, once the blood supply in the muscle is diminished, eventually at last the nerve supply, the muscle means the blood supply to the nerve will also be eventually affected, and this may be one reason, and the other reason can be due to the edematous hypertrophy of the muscle, the nerve may get compressed. Means there are two types of nerve, no? So if the sensory nerve are compressed, then they will called paraesthesia. Paraesthesia. Whereas if it has involved the motor nerve, it will cause paraplegia or paralysis. Paralysis. And once the blood supply is diminished, then the earliest feature in this limb will be pallor and poikilothermia, means cold calamities. Then poikilothermia. Okay, so these were some of the P's which should be remembered in the ischemia. Okay, once the ischemia is stabilized, it can affect the pulse, means whether it can be diminished or absent. Pallor and poikilothermia are the earliest manifestation, and at in later phases there can be sensory nerve compression, which will result in paraesthesia, and motor nerve will result in paralysis. And when the pressure in the compartment increases, it may also pressure in those compartment also undergoes increase, and once this is stabilized, it can even cause compartment syndrome. So these were some of the clinical presentation of the acute limb ischemia. Then the atherosclerosis. As we know that atherosclerosis is the plaque of lipid formation in the intimal layer of the vessel, and once the main reason or the risk factor for this atheroscleroma presence origin is the is due to the lipid, means once the cholesterol or the LDL is increased, then it can form atheroscleroma or atherosclerotic plaque in the vessel, and then it can cause occlusion of the vessel and diminished blood perfusion to the distal part. And the other risk factor can be diabetes mellitus, hypertension, sedentary lifestyle, high fatty diet. So this will give you a clue about the arterial origin due to the atherosclerosis. Okay, and so these were some of the variant of the arterial disease, and we should be asking about this related important feature to differentiate among the different arterial disease. So now we will start from the history taking of a peripheral vascular disease patient. Okay, we will start the history from the patient particulate. Means simply in patient particulate we will ask for the age of the patient, sex of the patient. Means as I said, atherosclerosis is more common in male, whereas the Reynolds phenomenon or the Reynolds disease is more common in young female. Okay, Buerger disease is more common among the male and those who are in between 20 to 40 years. So these are some of the means in patient particulates. We will ask for the sex of the patient, whether the female are more prone to Reynolds disease and Buerger disease, whereas Buerger disease is more common in case of male, whereas Reynolds is more common in female. Atherosclerosis is found in more means elderly patient. Okay, then we will come to the their clinical presentation. We will also ask about the site, means which limb is affected, whether lower or upper limb, means to differentiate whether it is Reynolds or Buerger disease, because Buerger is more common in lower limb, whereas the Reynolds is more common in upper limb. Okay, whether it is bilateral or unilateral. The Buerger disease is usually bilateral, whereas the Reynolds involves even the Reynolds can be bilateral, whereas the atherosclerosis whether unilateral or bilateral. Atherosclerosis usually is unilateral, whereas the Buerger and Reynolds is bilateral type. Then we should also ask about the relevance history of diabetes, hypertension, to get a clue about the atherosclerosis. Okay, then the mode of onset. Usually the atherosclerosis takes a long duration for its onset, whereas the Reynolds disease is usually very sudden, immediately after the cold exposure. Okay, so this is about the. Then some of the patient usually present with the pain, and if he presents with the pain, then we should proceed with the shock rate, means site onset character, radiation, timing of the pain, exacerbating and relieving factor, shock rates, associated features, and at last the severity. Actually this patient who present with the pain is asked for the intermittent claudication. इंटरमीडिएट क्लाउडिकेशन का मतलब क्या होता है, मीन्स द पेशेंट ड्यू टू द क्रैम्पी टाइप ऑफ पेन इज प्रेजेंट इन द मसल ऑफ द लिम्ब ड्यू टू द आर्टेरियल occlusion, and once the arterial occlusion is established, there will be anaerobic respiration and usually cause lactic acid and substance P to be accumulated in the muscle, and these are the main thing, means the lactic acidosis and substance P accumulation are the reason for the pain during walking or during moving legs. Okay, intermittent claudication में क्या होता है, this is the pain due to anaerobic respiration once the ischemia in the limb is established. Okay, and this patient usually indicates the site of the pain as in the calf muscle, foot, buttock and thigh. Okay, and the most common artery involved in this intermittent claudication will be either popliteal, anterior or posterior tibial, or dorsalis pedis. Okay, and to differentiate between the arterial and neurogenic claudication, the arterial claudication is present once the patient starts moving for some distance. Okay, and it usually regress once the patient stops. Okay, after stopping his movement, the claudication or the pain is stopped after 5 minutes. Okay, but the neurogenic type of claudication usually is resolved immediately after the patient starts walking. There are two types of claudication, neurogenic or arterial cause. So arterial persists till the patient is walking, whereas the neurogenic is disappeared after the patient is walking and usually present at rest. Then we should ask about the ulcer or gangrene and cold history, means sensitivity to cold, to differentiate for the Reynolds disease. Okay, some of the other features like fainting, transient blackout, chest pain should also be asked for the atherosclerosis. Okay, other symptoms should also be, means other associated symptoms with the peripheral vascular disease should also be asked. Then to complete the history, we will ask about the past history of cardiac disease exposure to cold or diabetes mellitus and cold and collagen disease. Okay, past history and personal history regarding smoking, because it is useful in case of Buerger disease. Then we will ask about the dietary habit. Dietary habit में why is it important? Dietary habit is asked due to the to find the amount of the lipid which is predisposes to the condition like atherosclerosis. and any sort of medical or surgical history is present in that patient or not. So these are the important history component to find to reach to a conclusion or to find a clue about the origin of the disease. Now our main concern is for the inspection and palpation of the vascular disease. Under inspection, we will start with the attitude of the limb. Actually, the patient with arterial disease tries to put their leg below the level of the table or bed. Okay, means when the leg is lower down, then the arterial supply can be elevated, so it resolves the pain. So they try to usually sit down and put their leg down to the table or bed. Okay, so this is about the attitude, relevance of the attitude in inspection. Then we will look for the deformity, whether any sort of deformity in the appendages or any presence of other previous scar or ulcer is present or not. We will look for the deformity. Then the muscle wasting. Muscle wasting is usually seen in case of calf muscle and other quadriceps. And condition of the vein. Now the condition of the vein should be looked. Normally it is filled or not, any discoloration of the vein is present or not, guttering along the course of the vein or not. Okay, and vein का condition देखेंगे. Then we will go for the sign of peripheral ischemia. As I said earlier, peripheral ischemia में क्या sign आ सकता है? We will look for the pallor due to arterial occlusion. Peripheral ischemia का sign. So this is very important. We will look for the change in the color of the skin, because if the artery is occluded, then there will be pallor. Okay, then we will look for the either pallor or cyanosis can also be there. Due to the occlusion in the artery, there may be thin shiny skin. There may be decreased growth of hair growth will be decreased, and there can be nail changes like brittleness and transverse ridge can be present. Nails में क्या होता है? The nails become brittle. उसके बाद even in the late manifestation can be some ulcer can also be seen. Okay, and so these were some of the feature of ischemia in the limb. Okay, we should also look for the gangrene, and we will look for the site color odor. Actually the dry gangrene has a H2S gas, and so it will be there will be odor present in the foul smelling odor will be present in the gangrene of the dry origin. Okay, we will also look for the gangrene demarcation line in the gangrene, usually more marked in case of dry. Okay, and then the important test which we will perform in the inspection is the Buerger postural test. Buerger's postural test में क्या किया जाता है? The patient is asked to elevate the leg up to 20 degree. Okay, when the patient is in supine position, we will ask the patient to elevate his leg up to 20 degree and keep for about 2 minutes. Buerger postural disease. So during putting the leg in elevated position, the patient, if the arterial occlusion is present, the patient will the leg of the patient will be either pale or some sort of discomfort will be felt by the patient in the presence of ischemia. Okay, simply we performed the elevation of the leg up to 20 degree, and then we ask the patient to keep it for about 2 minutes, and we are looking for the pallor and discomfort. The other test will be our vascular angle or the Buerger angle, the angle at which the person, means suppose that we asked for the 20 degree, to keep the 20 degree, the patient was easily putting his leg in elevated position up to 20 degree, then we will gradually increase the angle to 30, 40, 30, 45, and we are just increasing the angle and asking the patient to keep his leg elevated, and we will find the angle at which the person is feeling discomfort and the pallor appears. Okay, so the angle at which pallor or discomfort is felt, that will be called as Buerger's angle. And the other test will be capillary refilling time, CR, capillary refilling time, and the venous refilling time, venous refilling time. For capillary refilling time, we will simply elevate the leg and ask to sit. After elevation of the leg, the patient is asked to sit, and having his leg down by the side of the table, we will look whether the blood again came down, means while elevation of the leg, if there is ischemia, there will be pallor. Okay, and if the obstruction is severe enough, even after the leg is down, and we are looking for the disappearance of the pallor, and the time for the disappearance of the pallor is usually elevated in case of ischemic disease. Okay, usually in ischemia it will take about 15 to 20 to 30 seconds. Okay, 20 to 30 seconds to recover from the pallor. Okay, this is the time to recover from pallor after the elevation of leg. एंड वेनस रिफिलिंग टाइम में क्या किया जाता है कि अगेन द पेशेंट लिम्ब इज एलिवेटेड फॉर सम टाइम, एंड इन नॉर्मल लिम्ब देयर विल बी गॉटरिंग ऑफ द वेन देखा जाता है, तो जिसमें इफ़ अ पर्सन इज नॉर्मल में क्या होता है, द गॉटरिंग इज फेल्ट ओनली एट 90 डिग्री एलिवेशन, whereas if there is ischemia, if there is ischemia, the venous return after the elevation will be is delayed, and the gauntering of the horizontal vein is, ischemia के केस में क्या होता है, the gauntering is felt even at 10 degree elevation. Okay, and the time taken to be for the venous return to come back will be about 20 to 30 seconds as in case of the CRT, and it is delayed in case of venous refilling time. So these were some of the inspection point. We saw about the attitude, deformity. Attitude, the patient with arterial occlusion usually keeps his leg down, and deformity, whether any sort of appendicular deformity is present or not, ulcer is present or not, muscle wasting in as a late complication of the ischemia, then vein, patency of the vein, and vein का जो vessel है, that is also examined. Then the peripheral ischemia का sign, which we will look for the color, thinning and skin and hair. अब क्या होता है, तो स्किन में थीन एंड साइनी स्किन हो जाता है, हेयर ग्रोथ इज डिक्रीज्ड एंड नेल बिकम्स ब्रिटल, एंड एट लास्ट देयर में बी अल्सर प्रेजेंस. देन वी सॉ अबाउट द गैंग्रीन विच इज डिफरेंशिएटेड इनटू वेट एंड ड्राई गैंग्रीन. एंड पोस्चुरल, बॉर्जर पोस्चुरल टेस्ट में क्या किए, वेयर ड्यूरिंग एलिवेशन ऑफ द लेग वी सॉ द एंगल एट विच देयर इज पैलर एंड डिस्कम्फर्ट, एंड विच इज कॉल्ड एज बॉर्जर एंगल. वी सॉ फॉर द कैपिलरी रिफिल टाइम बाय एलिवेटिंग द लेग, and after after elevating, the time which is taken for the capillary refilling, and usually in ischemia it takes about 20 to 30 seconds. And venous refilling time में क्या हुआ, फिर से we elevated the leg, and if there was gauntering of the vein at 90 degree, then the person is normal. If the gauntering appears even at 10 degree, then it is ischemic cause, and the time for the venous refilling is also delayed in case of vascular disease. Okay, so now the most important component of the examination is the palpation. Regarding palpation, we will again confirm the inspectory finding by looking for the capillary refilling time and venous refilling time. For capillary refilling time, we will press the pulp of the toe or the fingertip of the nail for few seconds. Means simply by if it is the toe, then we will press this toe for few seconds and we will look for the capillary refill time. Usually it is delayed in case of ischemia. Okay. Then for the venous refilling time, we will simply suppose that this is the leg, then we will put the and in this region the venous flow is going, then we will put the index finger in this manner and simply we will press both the side, and immediately after leaving it we will look for the flow in the venous. Means it is actually delayed in case of ischemic limb. Okay, so this is just for the confirmation of the inspectory finding. Then we will some of the specific test which is performed in this case is the Fuchs sign. Okay, Fuchs test. Fuchs actually this is Fuchs sign, Fuchs test. And how is it performed? The patient is asked to sit with the crossed leg over one another. Okay, patient is sitting with crossed leg over one another, and so that the popliteal fossa of one leg will lie against the knee of the other leg. Okay, simply he is sitting in the chair with the popliteal fossa of one leg over the knee of the other leg. Okay, then in normally क्या होता है, if the patient is sitting cross legged, then there will be oscillatory movement of the upper leg. Okay, if the popliteal pulse is present. Okay, and if the popliteal pulse is absent, there is no oscillatory movement. ओसिलेटरी मूवमेंट होना चाहिए. अपर लेग जो हम लोग क्रॉस लेग के मेथड में रखे हैं तो ओसिलेटरी मूवमेंट होना चाहिए. बट इन इस्केमिया और popliteal if the popliteal pulse is absent, then there will be no movement. Okay, so this is called as Fuchs sign. Then we will also look for the reactive hyperemia. In reactive hyperemia test क्या करते हैं, the blood pressure cuff is inflated up to 250 mmHg. reactive hyperemia हम लोग कर रहे हैं. The blood pressure cuff is inflated up to 250 mmHg, and after inflation up to 250 mmHg, we will keep about 5 minutes. We will keep for 5 minutes, and then we will look for the appearance of the pallor. Okay, and once the pallor is appeared, pallor होगा, तो pallor होने के बाद में we will just deflate the cuff and look for the normal flossing. Okay, what is the time it will take to take for the flossing? Normally in a normal person it takes about only 1 to 2 seconds for flossing or reperfusion, whereas it is delayed in case of ischemia. Ischemia है तो it is delayed. Okay, did you got it? Reactive hyperemia, as the name suggests, means simply we inflated the cuff up to 250 mmHg and we kept for about 5 minutes, then pallor will appear, and once the pallor appears we will deflate the cuff and look for the reperfusion in the limb, and it will take normally 1 to 2 seconds, but it is usually delayed in case of ischemia. Then the other test is for the cold and warm test. In this patient, cold and warm test में क्या करते हैं, the patient is asked to put his hand in cold water, and once he put his hand in cold water, if he is cold sensitive, as in case of Reynolds syndrome, the hand will be pallor. Then this pale hand will be again asked to be put in warm water, and again this color of the hand will change to blue color. So this is very diagnostic for the Reynolds stages. Okay, usually it is and this blueness is due to the cyanotic congestion. Okay, now the other test is called as elevated arm test. Actually this is done in case of thoracic outlet test obstruction, elevated arm test. In this elevated arm test, the patient is asked to abduct his hand 90 degree and then in external rotation is done in this way, and after external rotation he is asked to open and close his hand for about 5 minutes, and if the thoracic outlet is obstructed, the patient will not be able to perform opening and closing of hand. Okay, usually he feels fatigue, pain in the forearm, there may be tingling or numbness over the finger or paraesthesia. Okay, this signifies that there is thoracic outlet obstruction. So this was for the thoracic outlet obstruction. Then the other test is the Allen test. In Allen test, the patient is asked to clench his fist tightly and press over the radial and ulnar artery. Ask the patient to clench the fist tightly and press on the radial and arterial ulnar artery at the wrist. Okay, this is Allen test. By pressing the radial and ulnar artery at the wrist, and up to 1 minute ask the patient to close and open for several times till the palm become pale. Okay, actually we have pressed the wrist and the patient is asked to open and close the wrist for few times. Okay, and once the distal part of the palm gets pale, then one of the artery, means suppose that I will release the radial artery in this portion, then by putting my hand over the ulnar artery, and then in normal person even the one artery is sufficient enough to perfuse the distal part of the limb, but if the radial artery is obstructed, then the paleness will not be resolved and will persist even after relieving the radial artery. And the same procedure can also be conducted for the ulnar artery too. We will again compress the wrist and ask the patient to open and close his hand for few times, and after the pale is appeared in the distal part or the palm, we will again release the ulnar artery and by compressing the radial artery. And in normal person again the ulnar artery should be enough to reperfuse the distal part of the hand. This is the Allen's test. Allen's test will show you the radial and ulnar artery का patency, ulnar artery, and these are the important tests which is usually performed in case of the arterial disease. And at last, under auscultation we will look for the systolic bruits, which is due to the turbulent blood flow beyond the stenosis. Okay, systolic bruit is seen due to the turbulent blood flow